So the research and data that I presented here at LINC yesterday was really driven by the fact that we're still searching to get a solution to our concerns about paclitaxel. We don't know for sure whether paclitaxel leads to a higher risk of long-term mortality, but the information is really starting to crystallize. What I presented is a small piece of that puzzle. The key thing is that whenever an exposure of a particular drug or a particular toxin is thought to have an associated adverse event, there are certain specific things that you want to look at to evaluate the potential for a relationship. In the case of the medical care of patients where we're deeply concerned, if there is an increased risk of mortality, we want to see, is this simply an association driven primarily by statistics and trial design, or is this actually a causal relationship between paclitaxel and any difference in mortality that the patient cohorts might experience? So the way we investigate that is by looking for specific criteria. For example, is there a dose relationship? So if this is a harmful material, a small dose should be bad and a large dose should be worse. So is there a dose relationship? Secondly, is there what I would call a mechanism? So is there the possibility that this agent could actually cause the outcome that we're concerned about? It's like, what's the biological mechanism? And then thirdly, and this is where my presentation or where my information came in, is there consistency? In other words, if it's dangerous, it should be dangerous wherever it's tried in whatever population it's used. And so, and this is termed consistency. Is there consistency within the data that there is definitely harm or definitely not harm? So what I did then was I did some analysis of lots of data sets that have been presented. And so for example, there was a so-called signal, some sign of increased mortality in the randomized trial population, but in the population of what I would call real-world data, there has yet been no signal identified. So it's really inconsistent. So one population seemed to have an effect, another population it seemed not. And so then doing a deeper dive, what I specifically was interested in is the geographic representation of patients, because these studies have been done all over the world, literally. And so the question is, if it's dangerous, it should be dangerous wherever it's used. And so we looked at trials that were done in the United States, for example, and trials that were done in other countries such as Japan and the various countries of Europe, et cetera. And what we have found, and this was also detected by the FDA on some level when they did their analysis, is that the danger sign or danger signal seems to be only within the United States. So it's not geographically consistent. It appears that the trials done in Japan especially, and also in the European countries, show no signal or certainly no sign of danger in that setting. So that lack of consistency really indicates or speaks against a causal relationship. The clinical implications are these. The danger, if there is any, of paclitaxel, it appeared about a year ago from now to be a wide open question. And although I wouldn't call it that it's not completely solved, so I wouldn't call it a solved issue, I do think a tremendous amount of information and knowledge has been gained in this past year that has helped to do what I would call crystallize the direction that we're going in, and also to answer some of the issues related. So for example, I mentioned some of the criteria we look for to identify a causal relationship. So one would be, is there a mechanism? And none has been found so far in all of these different studies, both in the randomized trial and the real world data. the there hasn't been any clustering of deaths. So in other words, if there is a specific biologic mechanism, it should produce a specific adverse event, a cluster, let's say, and that hasn't been the case. The other major piece of the puzzle is that the potential for a dose relationship or biological gradient has been investigated by multiple authors, multiple studies, and no dose relationship has been identified. And then thirdly, the consistency argument, the concept that I'm presenting about this difference between patients in certain trials and also in different geographic areas, not showing consistency in terms of any potential risk there. So all of these data appear to be heading directionally toward the same answer, and that is that the risk of paclitaxel is either very small or there is none with respect to long-term mortality. Like I said, it is not a completely answered question at this point. We have more to do, and I'll just give some examples. One is that we will gather more data because there are randomized trials that have been enrolled that now continue to be in follow-up. And so we will have longer-term data from Illuminate specifically, which was presented yesterday here at LINC and will, I'm sure, go into publication form at some point. Secondly, we will have some data from Ranger. Now, the Ranger trials come from Boston Scientific, and these were not included in any of these meta-analyses, but fortunately it is a randomized trial between patients who receive paclitaxel-coated balloons and versus plain balloons. So we'll have that data to include. And then in addition, since the issue first came up, there's been a tremendous improvement in the ability to find some of the patients that were previously lost to follow-up. And with that data, we gain more insight as to what the different trial design differences are, and also what the true risk is, because ultimately, if a patient has been lost to follow-up, you don't know if they've had a mortality event or not. Once you find those, you can put them in the correct category and take another look at the information. So all of these things are happening, and I suspect that as they accumulate, the answer will become even more clear. I believe that with the initial meta-analysis publication, just again, a little over 1 year ago, there was a dramatic change in clinical practice. And this is reflected differently among various countries, but in general, there was a dramatic decrease in the use of drug-coated balloons in the lower extremities. What has happened now is, as information has continued to accumulate, a lot of practitioners have gone back to using it more frequently. The other thing that did happen is that the FDA, the U.S. Federal Food and Drug Administration, what they had said in their earlier letter of March, which was very much, it appeared to be a stern warning about their concern, ameliorated at least a little bit in their letter of August. And this gives people also more confidence. And for example, they suggested that if patients are at particularly high risk for restenosis, that you should consider paclitaxel, or at least that you have to weigh the risks and, or at least potential risks and benefits. And so I think this has affected practice, and a number of clinicians have now started to try to reincorporate drug-coated balloons into their practices, but it's highly individual, and there's no specific algorithm at this point.